Indian College of Ayurveda Udupi to take over the session. Welcome, sir.
Okay, welcome. Okay, now in the previous session we are discussing about the cirrhosis of the liver and its clinical presentations and complications. We have discussed about the portal hypertension and then the next part of it would be hepatic encephalopathy. Hepatic encephalopathy is a irritation of the brain and nerve endings due to the impairment of the liver functions. One of the important functions of the liver is a conversion of the ammonia into urea. Ammonia is highly toxic to the nerve tissues, and if at all there is a failure of the liver functions, it can result in the damage to the or irritation of the nerve fibers in the brain, and it can produce the changes, and that's what we call as a hepatic encephalopathy, which can be of different degrees. It may present with the usual clinical presentation would be patient may have a personality changes, intellectual impairment, depressed level of consciousness, which often may give a feeling like the patient has some psychiatric illness. Along with that, the patient also may be presented with the extrapyramidal symptoms like tremor, bradykinesia, rigidity, or gait being altered, or in very severe cases, it may even result in coma. The conditions of that hepatic encephalopathy are triggered if the patient of cirrhosis has the complications like renal failure, or if the patient has a gastrointestinal tract bleeding, or if the patient develops many infective pathology, a persistent constipation, if the patient develops hypovolemia, or if due to for the cirrhosis and the ascites when you give diuretic therapy, if the diuretics are given more than what's necessary, that also can trigger the hepatic encephalopathy. Many of the drugs like antipsychotic drugs, opiates, benzodiazepines, these also can trigger the hepatic encephalopathy. So a patient presenting with the encephalopathy symptoms, you need to confirm whether these underlying pathologies are there or not. Now, hepatic encephalopathy is again graded into 4 grades. Grade 0 is where there is a minimal encephalopathy signs, but a known case of cirrhosis who had an episode of hepatic encephalopathy earlier, and there may not be any obvious changes in the personality behavior, minimal changes in the memory, and so on. And the gait also is not significantly abnormal. Grade 1 is a trivial lack of awareness. That's slightly the patient may have a shortened attention. This patient is not able to do simple mathematical work like addition or subtraction, like patient may find it difficult, or the patient may have minimal changes like either increased sleep or loss of sleep or change in the sleep pattern. At times it could be the mood elevation, or at times it could be the depression or irritability. These are what called as grade 1 conditions. Grade 2 is where the patient has a significant lethargy or apathy, disorientation, inappropriate behavior, slurred speech, or patient visibly abnormal gait, atherexis, abnormal gait, tremors, etc. And patient is not able to perform gross mental tasks like, and inappropriate behavior is quite obvious, and that patient may also have a disorientation. Grade 3 is where the patient is significantly like somnolent, completely sleeping like, and he may be moving in a sleepy condition and absolutely unable to perform many mental tasks, and marked confusion, amnesia, or fits of rage also can be presented in grade 3. Grade 4 is patient has a coma. Now the issue is management of the hepatic encephalopathy is possible up to grade 2. Grade 3 and grade 4, it needs an intensive care treatment. The general treatment prescribed, or general line of treatment prescribed is virtually there is no curative treatment. The only treatment for reducing the ammonia load is ornithine or aspartate, L-ornithine or L-aspartate, as well as zinc and sodium benzoate. These are given as a symptomatic treatment to facilitate the ammonia clearance, but none of them are a definite treatment. In a grade 3 and grade 4, this treatment also would not be helpful. In grade 1 to grade 3, to prevent grade 1 to grade 2, grade 0 to grade 2, to prevent further episodes, you may give diet, suggest about the diet, the usual diet like a low protein diet. Actually, in general, in a hepatic pathology, high carbohydrate and moderate protein is given. But in patients with encephalopathy, it's better to reduce the protein because protein is a major source of this ammonia. And then there is another custom of administering non-absorbable antibiotics orally. Antibiotics which are not absorbed orally, like gentamicin or maybe streptomycin, given orally. It's important, it has to be given orally so that the colonic bacteria will be reduced and hence the bacterial decomposition reduces and hence the ammonia produced also can be reduced. That's the idea of the treatment there. Or cathartics like purgatives, so that the stools would not be accumulated, ammonia absorption could be reduced. In the initial stages of this hepatic encephalopathy, we can manage the patients with the Smith-Sagarasa, Kamavaka, Saraswata plus Virechana also can be useful. But in grade 2B above, this treatment may not be enough to manage. Patient may need an intensive care treatment. Then the next is the hepatorenal syndrome, another of the complication which can occur in patients of cirrhosis could be, and it's a complication of the renal pathology where either there could be a renal vasoconstriction as a result of this sequence of series of the complications of cirrhosis. Cirrhosis can produce cardiomyopathy, cirrhosis can, the portal hypertension, all of them can result in a arterial hypovolemia and hence the patient's blood vessels, renal blood vessels can be constricted and it results in a reduced glomerular filtration rate and hence results in kidney tissue injury, or it could also due to the inflammatory response like because of the encephalopathy and ammonia toxicity, the toxic substances which are not really detoxified by the liver may damage the kidney, and in both the ways the hepatorenal syndrome can occur. And in a typical hepatorenal syndrome of patients of cirrhosis, patient would have the clinical presentations of the renal failure. It could be like the uremia symptoms like nausea, vomiting and pedal edema throughout can occur, or the biochemical assessment of creatinine level also may be raised. Now, based upon the pathology, the hepatorenal syndrome is categorized into two types. Type 1 is post-infective, where the patient has an episode of infection and following that the patient has a renal pathology. Type 2 is due to the portal hypertension and cardiac myopathy, there is a vasoconstriction and hence the patient has the renal pathology. In general, prognosis of hepatorenal syndrome is extremely poor and the only lifetime treatment could be dialysis, and dialysis also is not going to help much as such. Only temporarily it can be helpful, and in general the survival period in case of type 1 is just 2 weeks, whereas in type 2 it's around 3 to 6 months where the patient has a vasoconstriction and hence has developed the renal failure. You can pull on the patient with the renal supportive treatment like dialysis and for a certain period like 3 to 6 months, whereas in the type 1 in post-inflammatory survival period is very low and hence it's again the prognosis is extremely poor and it's often considered as a end stage complication. The other hematological manifestations of the cirrhosis could be hypersplenism, where the spleen size could be enhanced, and as the spleen size is enhanced it can result in the hemolysis. RBCs are destroyed frequently and hence the patient may develop anemia. There could be iron deficiency because the liver is not able to store the iron and hence the patient develops iron deficiency. Tendency to have the bleeding because vitamin K and the coagulation mechanism and formation of the prothrombin, all that mechanism would be affected and hence the patient would have a increased bleeding time as the clotting time would be enhanced. The collagen tissue also becomes fragile, and because of the fragility of the collagen tissue, patient may have enhanced bleeding time, and because of the impairment of the clotting factor and that cascade of the clotting phenomena being affected results in increased clotting time, and the patients also would have vitamin deficiency, particularly B and B12 B series vitamin deficiency. Of course, there is no specific curative treatment for these complications. The treatment would be only symptomatic, like supplementing, iron supplementing, bleeding tendencies, vitamin K is supplied, and other vitamins also are provided. So usually in case of cirrhosis, These also are the part of the management, like supplementing asset. And of course, a very common presentation of the cirrhosis is ascites. Ascites, where the patient may have a fluid in the abdomen. A patient of ascites, fluid in the abdomen, is not necessarily of cirrhosis. There could be ascites produced due to other conditions also. Fluid could be presented in the abdomen due to inflammatory pathologies, exudative pathologies, like any perforation or any peritonitis, any cause of peritonitis can produce ascites. Ascites also can be produced as a complication of the malignant lesions in the any visceral organs, where there could be hemal, the blood would be collected, and it could be presented that way. Or ascites could be due to the renal, hepatic pathology. Hepatic pathology is producing the ascites again is categorized into post-hepatic, hepatic, and prehepatic. Prehepatic is when there is portal vein thrombosis like conditions, which we have discussed in case of portal hypertension. The same issue, a portal hypertension of three categories. All the three categories can result in ascites. And non-portal hypertension conditions could be many, like protein abnormalities or inflammatory pathologies as such. These also can be presented as such. Now, classification of this would be based upon the protein content in the ascites fluid. If it is protein rich, it is usually of inflammatory pathologies like tuberculosis, pancreatitis, etc., or malignancy also. If it is protein poor, it is nephrotic syndrome like conditions. And in cirrhosis like conditions, you may have the portal hypertension signs, and any of these causes could be producing the ascites. So ascites is not only a product of the cirrhosis. It's not that every patient having an ascites has a cirrhosis, but the other way, like every patient of cirrhosis at the end stage can end up in ascites. That's also true as such. Now, in a case of ascites conditions, patient presenting with the ascites condition, the protocol of dealing with the ascites would be, the first would be you will have to see whether the serum ascites albumin gradient, that serum, the ascites fluid albumin has basis and the serum albumin also has basis. And this is one of the important criteria to make the diagnosis. If the ratio of serum albumin and the serum, this ascites albumin, the fluid in the albumin in the ascitic fluid, if it is 1:1, that's almost same, or less than 1:1, then the causes could be biliary, pancreatic ascites, etc. If the ratio is 2:2.5, is the ascitic protein, the ascites fluid protein is high, like it's less than 2.5 grams, it's low as such, then it's suggestive of the chronic heart failure, etc. When the ascitic fluid shows a polymorphonuclear leukocytes, increased number of polymorphonuclear leukocytes like more than 250, then it's suggestive of a bacterial peritonitis. The rest of the other conditions, you can conclude that it could be cirrhotic ascites. So whenever there is a clinical suspicion of a patient of ascites, you have to rule out the other causes and confirm whether it is a cirrhotic ascites or not. In a cirrhotic ascites conditions, now I will not deal with the other ascites conditions. The management of the cirrhotic ascites is primarily by administering diuretics, and diuretics like these potassium preserving diuretics like aldactone, or maybe facilitate that activity of the aldactone. You may give a small combination of furosemide, the lacilactone, which is given. That is the usual symptomatic treatment for the ascites. Aspiration of the ascites is to be done only when there is a very huge ascites and it affects the breathing. So if the breathing is affected and the respiratory movements are significantly affected, then only as temporarily the aspiration may be done. Otherwise, aspiration has to be deferred or postponed to a great extent as far as possible, because aspiration will result in a sudden changes in the fluid and electrolyte status of the body, and also the protein content of the body also would be reduced, and there is no definite means of preventing further accumulation, and hence aspiration has to be postponed till it is absolutely necessary. Then of course the last alternative treatment would be the liver transplantation if possible. Now from our Ayurvedic management point of view, what I would just generally prescribe would be, of course, this aldactone is generally prescribed in patient of ascites. Along with the aldactone, administration of Gomutra with the Triphala, Arogyavartini, Punarnamandur and Kumariyasava can help a lot and postpone the complications significantly. Though there is no question of a cure, a significant avoiding or postponing of the complications is possible. Then, of course, it's almost a repetition of the same. All the patients of hepatic cirrhosis may end up in, it's not only hepatic cirrhosis, almost every disease of the liver may end up in either a chronic hepatic failure or acute hepatic failure. Chronic hepatic failure, the symptoms produced are quite diverse. You will have plenty of these typical presentations of that chronic hepatic failure, which present throughout the body. Like it could be like neurological symptoms like hepatic encephalopathy and these tremors in the body. The patient may have a visible jaundice. Due to the fragility of collagen tissue, patient may have the spider, the signs like subcutaneous hemorrhage signs, erythema in the palm, and there is a typical liver palm where the palm would be quite swollen and that purpura could be seen, reddish dots could be seen. Then portal hypertension, it can produce the typical esophageal varices and gastric varices, then melena, and then this hematemesis, anemia, which we have discussed. Caput medusae due to dilated umbilical veins and ascites, of course. Anorectal varices also can be occurring. Testicular atrophy, gynecomastia, and amenorrhea in case of hepatic failure because of impaired metabolism of the hormones. The testicular hormones as well as ovarian hormones, their metabolism is affected in liver failure, and hence either it's a testicular atrophy or gynecomastia in males, amenorrhea in females. Then it also can be presented with the symptoms of hematologic symptoms like thrombocytopenia, anemia, bleeding tendencies, hepatorenal syndrome, and hyperbilirubinemia. Bilirubin in the system would be enhanced, and there could be peripheral edema, cardiomyopathy. These are the total complex symptoms of a chronic hepatic failure. Of course, we have discussed all these symptoms in different stages as complications of the cirrhosis. So, a patient of hepatic failure, chronic hepatic failure, may present with all of these or a few of these symptoms as such. So, every patient has to be evaluated for the severity of the hepatic failure. And the hepatic failure again can occur due to the fibrosis of the liver, and it's categorized into either a pre-cirrhotic conditions or a compensated cirrhosis, or where the hepatic failure can be compensated, and decomposed cirrhosis, decompensated cirrhosis is where the patient would be having all the signs of hepatic failure. So, in a patient of cirrhosis, it may take a long time, depending upon the other precipitating factors. On an average, a patient of cirrhosis may present with just fatty changes, minimal changes, and he may continue for 10 to 15 years with the pre-cirrhotic conditions, all the diseases which do not really present as cirrhosis. A compensated cirrhosis patient may survive for another 10 to 15 years, and the patient may still survive with the decompensated cirrhosis for 3 to 4 years. If the patient has to survive beyond that, then the liver transplantation or the death, liver transplantation or the death is the only other choice of the presentation. So, course of the cirrhosis is a prolonged course, and it's difficult to predict the prognosis. It's difficult to say like how much of your treatment can help the patient. So that's all the point. But still, with our management, our Ayurvedic management, we can have certain definite outcome, more positive outcome, and maybe to a great extent reversibility. The condition can be reversed to a great extent, but it's not absolute. You cannot say like every patient can be reversed. That's about the cirrhosis. The incidence of the death due to cirrhosis is increasing every year, though with all the technology and with the liver transplantation, though the death number may be reduced to a certain extent, incidence of the liver pathology throughout the globe has not really reduced, rather it's increasing, and particularly it's more increasing in the male sex than the female. And the reasons are mainly the dietary and the lifestyle factors. Death may be reduced due to the liver transplantation. So, liver transplantation has made some changes in the outcome of the liver cirrhosis, but incidence cannot be changed. So, that's about the chronic liver failure conditions. Then there is another condition which we generally say as acute liver failure. Acute liver failure which can occur due to various conditions. It's not only cirrhosis. Due to multiple toxic conditions or very common toxic conditions. When there is a sudden infective pathology like viral hepatitis also can present in the acute liver failure. Liver failure also can occur due to vascular complications where there is a thrombosis. Now, the condition is difficult for identifying that acute liver failure many times, where the patient presents with acute symptoms, and hence there is a need for a standardized definition. And the standardized definition of acute liver failure is when the bleeding time is enhanced and the prothrombin time is enhanced by about 1.5 ratio, INR ratio, normalized international normalized ratio of prothrombin time has increased beyond 1.5, and the patient presents with the neurological dysfunction with any degree of hepatic encephalopathy, with no history of previous liver disease. If the patient has a previous disease, liver disease, we generally categorize that patient as a chronic hepatic failure. If there is no evidence of that, and the patient has a disease course of less than 26 weeks, acute hepatic failure is defined as a acute impairment of the liver functions with the neurological symptoms and a bleeding tendency, but INR is more than 1.5, and the course is less than 26 weeks. Causes of the acute liver failure could be many, and among them, one of the important causes is paracetamol. Remember this, again I repeat this, paracetamol, I have repeated that, I have discussed about that issue earlier. Now, repeat the same issue. Many times the paracetamol is considered as a safe drug and sold on without prescriptions on the counter product, and there is a habit of consuming Dolo for every issue like, so it has become rather more frequent than the salt being used in the diet. Remember that this is one of the most important causes of the acute hepatic failure, particularly in children. And among the total conditions of hepatic failure, acute hepatic failure, drugs constitute 70 to 80%. And the other drugs which could produce acute hepatic failure, like it could be antitubercular treatment, particularly rifampicin, halothane, which is used as an anesthetic, patients with the drug, these addiction forming drugs like ecstasy drugs, and of course, as per the data, certain herbal remedies also, not Ayurvedic drugs, herbal remedies, certain of the herbs also are known to produce a hepatic toxicity. Of course, following the trend, some Kerala hepatologists have said that Amrita produces hepatic toxicity, Bangam, nonsense like, and that whole research is on the trends, on the lines of the Western concepts of certain herbs which produce acute toxicity. So that's all, we will not go beyond that. Then the mechanical or idiopathic, where some intervention has been done in the liver and it can produce the hepatic failure. It can be produced due to the hepatitis like infective conditions, viral infections like hepatitis A, B and C, D, then poisons like these amanita or any other carbon tetrachloride, another of the poisons which can produce. Then miscellaneous conditions like Wilson's disease or acute fatty liver, so on, these also can present with the acute hepatic failure. And manifestations of the acute failure would be having multi-organ failure. It can result in involvement of the multiple organs. Brain, it presents with the hepatic encephalopathy, cerebral edema and intracranial hypertension, seizures, unconsciousness or even coma. Heart, it can present with the initially high output ratio and then myocardial injury, and there could be what we call as the hepatocardiac syndrome, cardiac myopathy, and circulatory failure can result. Pancreas, it can present with the pancreatitis. Kidney, it can present with the typical hepatorenal syndrome and or even acute adrenal failure, which are severe electrolyte abnormalities, also can be presented in acute hepatic failure. And in the liver, of course, all metabolic functions glucose metabolism would be affected, and hence most of the patient would be presented with the hypoglycemia. But the moment you give glucose, there will be severe glucose intolerance and sudden shooting up of the glucose level. Coagulability of the blood is enhanced, or rather it's reduced, and the patient would not have a prolonged bleeding time, and tendency for the bleeding would occur. Acidosis is well known, and bone marrow also could be affected, lungs also could be affected, and hence acute liver failure is always presented as a, a multi-organ failure, and the outcome of treatment is very poor. It can be managed only with the specific system supporting treatment, and there is no question of treatment in a general hospital. It has to be in a ICU, and the usual protocol would be specific antidotes if the patient has this and infective pathology. Osmotic diuretics like mannitol, barbiturates are given, benzodiazepines are also given, anesthetic agents like propofol are given as the other options. The only choice of survival would be liver transplantation. Now, liver transplantation is a recent development in the field of medicine, and the incidence, the numbers of liver transplantation are increasing rapidly, and these indications are the liver transplantation also now are increasing, and most important is the alcoholic liver disorders and non-alcoholic steatohepatitis. These are the major now causes for major these etiological factors which result in end up in liver transplantation. Viral diseases are comparatively lesser, which form only 17% globally. But in the future trend, of course, the future trend would be like liver transplantation becomes now more popular because of the safety involved in it, and the results also are supposed to be better. So the future of the treatment of liver disorders ends up in the liver transplantation. So that's in general about the cirrhosis and the major issues related to cirrhosis. Now, a few of the other conditions which are actually part of the cirrhotic lesions only, but which require some certain specific mentions because of the clinical incidents and otherwise, and with an idea of covering up the whole chapter. Wilson's disease is another of the condition. Wilson's disease is a genetically transmitted disorder. Chromosome is identified, the responsible chromosome is identified, and it's presented with the abnormality of the metabolism of copper. The ceruloplasmin, which is the enzyme necessary for the metabolism of copper, is deficient in certain of the people, and this results in accumulation of the copper in the body. Deposition of the copper occurs in the body, metallic deposition, and it presents with the either three types clinical presentation. Impairment of the liver functions can occur mainly either as chronic active hepatitis or patients with the cirrhosis. Most of these would be patient may have a cirrhotic pathology, or rarely may present with a fulminant acute hepatic failure. The other clinical typical presentations could be extrapyramidal symptoms like dystonia, ataxia, often seen in children younger age, and also it can present with seizures or behavioral abnormalities. Though it's not a typical hepatic encephalopathy, you may not have that hepatic encephalopathy, but a Wilson's disease, though there is a tendency for the hepatic encephalopathy, the symptoms, neurological symptoms could occur due to the deposition of the copper in the body, in the nerve tissues also. Then in addition to that, the patient may have the additional manifestations like skeletal abnormalities like osteoporosis, osteomalacia, rickets, etc., and spontaneous fractures. As well as there could be cardiac manifestations like abnormalities of the rhythm or autonomic tone like tachycardia, sudden spurs of tachycardia, supraventricular tachycardia can be presented there. And there is a possible presentation of skin pigmentation and a bluish discoloration at the base of the fingernails, which are also called as azurinulae. Or another most common clinical sign of Wilson's disease is a brownish or greenish color ring around the iris, which is also called as a Kieser-Fleischer rings. The ring-like appearance around the iris is the common manifestation of the Wilson's disease, which is seen as such. Incidence of this is not very common, but occasionally you may see such patients as such. Management of Wilson's disease, because it is a genetic disorder, there is no question of treatment, curative treatment. The usual course of the treatment would be chelating agent to reduce that accumulated copper. The copper molecules have to be chelated, and the usual prescription is penicillamine. Penicillamine is relatively toxic and bit costly, also quite costly, and it has to be lifelong treatment. And the other symptomatic drug could be to reduce the tremors and epilepsy. Levodopa anti-epileptics are given. We have treated a few patients of Wilson's disease with the Bringarajasava and Arogyavardhini. Bringarajasava is prescribed with the idea like Bringaraja is used for Tamra Marana and in the Tamra Shodhana and Tamra Marana. With that idea, Bringarajasava is given. And I have seen many of the patients having some better results, like at least the clinical symptoms will be lesser. Copper level also has reduced to a certain extent, though not very remarkably. I don't say that Wilson's disease can be cured, but can be managed with the Bringarajasava and Arogyavardhini, and penicillamine can be avoided. Administration of the penicillamine can be avoided in a good number of patients. That's about the Wilson's disease. Another of the similar condition, which is comparatively less frequent now, frequency has reduced now, but earlier it was supposed to be common, and because I refer to this issue because it's considered to be a disease very specific in India. It's also called as Indian childhood cirrhosis. It's in only 1970s, the relationship between the source of copper in the vessels which are used for preparation and the disease was known, and now of course the incidence is lesser. So Indian childhood cirrhosis is a condition which is produced due to the excess of copper in the food. This is but is now accepted, believed. Like earlier there were a lot of other theories. Typically it presents with the three types of the presentation. Like early stage, it may present with insidious onset, and typical presentation would be a child, and it's usually presented in child, where the patient would have a disturbance of appetite, irregular bowel movements, and slight enlargement of the liver, or occasional jaundice, and a jaundice which is not consistent. It can occur, go, and so on. Usually the child would be malnourished. And in the intermediate stage, the patient may have a persistent jaundice, and there is a sign of irritability, marked hepatomegaly and splenomegaly also are seen, and ascites also may be seen as such. Late stages, the deep jaundice may occur, and it may result in hepatic failure and death. This is the usual course of Indian childhood cirrhosis. Initially, Indian childhood cirrhosis was not really, the real cause were not identified. Now it is identified as such. So, the major mechanism of confirmation would be by assessing the copper level in the plasma as well as the histological categories, histological identification, microscopic. That's liver biopsy is done, and with the liver biopsy, the diagnosis again is based upon the findings into mainly three categories. It's as a definitive childhood cirrhosis, Indian childhood cirrhosis, where you have advanced the deposition of the copper and micronodules are seen with the interstitial fibrosis. So a biopsy report would give you any of these three categories of the reports, like either definitive, probable, or inactive cirrhosis, based upon the findings. If there is a hyaline degeneration of the hepatocytes, which is typical, then it's confirmatory. And if there is no hyaline degenerations, then either it's categorized as probable or inactive. So if you take liver biopsy and the liver biopsy is done, then it would be suggestive of the different categories, the three categories of the disease. So confirmation would be when you have a definite evidence of the copper deposited and hyaline degeneration. The difference between Wilson's and the Indian childhood cirrhosis is the Wilson's disease can occur in much later ages also, like beyond 50 years also it is possible, but most frequent is 3 to 55 years. Whereas the childhood cirrhosis is usually most commonly seen in between 6 months to 30 months of life, and maybe up to 12 years, but beyond that is not known. Presenting symptoms are when the patient presents with these evidences, Wilson's disease, and you assess the blood picture, liver function tests are done, Aminotransferase levels, SGOT, SGPT levels would be raised remarkably. Jaundice and liver failure symptoms could occur. Neurological symptoms would occur quite late in Wilson's disease. Whereas in case of Indian childhood cirrhosis, the LFT findings initially would be non-specific. You may not have any specific feature, and ultimately, only in the late stages, the patient may have a liver failure. Till the end stages, the aminotransferase levels would be not raised remarkably, not very high as such. Then, of course, the histological difference in case of Wilson's disease, under the microscope, when you do the biopsy, you can see that melanocytic bodies, which is seen with deposition of the degenerated substance in the liver, and the liver copper level also would be quite moderately high, like 837 to 537. Whereas in Indian childhood cirrhosis, it's very high, like 100,600 as such. So it's a very high as such. That's about one. And genetic mutations, if you identify the genes, go for the genetic study, the mutations of the genes are identified in Wilson's disease, whereas in Indian childhood cirrhosis, the genes are not identified. So Indian childhood cirrhosis is a non-genetic pathology, though now there are some views like it's also related to a recessive genes as such, and the diagnosis is based upon these criteria. Differentiation also are based upon these criteria. That's about the other depositional disorders which can result in cirrhosis and as a part of the cirrhosis. So we will end up with that cirrhotic and chronic hepatic pathologies as such. Of course, there are many more conditions which could be discussed. I think that would be too many, so I will stop at that level. The next is about the liver abscesses. Liver abscesses again could be of different categories. Either it could be this pyogenic abscess, where infective pathologies are produced as such, or it could be due to the amoebic abscess. The most important are the infectious abscess, where it could be pyogenic abscess, where the spread of infection is through the bloodstream from the abdominal pathologies. Patients who have any infective pathology in the abdomen, like appendicitis, diverticulitis, and so on, it can result in a pyogenic abscess as such, or it could also produce due to the amoebiasis. Now, in addition to these, the other causes can be like intervention. Like if somebody, patients who have undergone a protocol procedures like either transarterial chemoembolization treatment in case of the tumor pathologies, or percutaneous embolization also. Tumor pathologies being treated with the direct interventions, or patients with the malignant pathology from the malignancy itself can result in abscess conditions, or patients who have undergone some surgical treatment also can result in the liver abscess. Metastatic liver lesions of the liver also can present in the abscess. So liver abscess could be of multiple origin. We will not go into the details of all these varieties. We will be dealing with only the amoebic and the pyogenic abscess conditions. Rest of the things are not very significant from the clinical point of view. The abscess in the Yकृत or Vidhrati in the Yकृत, Antar Vidhrati is mentioned in Sushruta, and all that you get, the description is very brief, like Shaso Yakriti to Snata. But further differentiation and the variations in the clinical presentations are not really mentioned as such. From the clinical point of view, the amoebic abscess, pyogenic abscess, and fungal abscess, these are the important conditions. And there is a very huge difference in the incidence of these conditions in the Western countries and in our India as such. The data in India, among the patients who present with the liver abscess, more than 75% or average of 75% would be of amoebic origin, whereas the amoebiasis is very low in case of Western countries, and comparable data from the USA, it's only about 10% of the abscesses. And hence, another important issue is many of the modern medical textbooks which are published on the Western data, Western statistics, it do not have much the information about the amoebic abscess, and most of the details are about the pyogenic abscess. So, and the incidence of the pyogenic abscess in the USA or the Western countries is around 80%, whereas comparatively it's 15% in India. But total incidence of the amoebic abscess, total incidence of the hepatic abscess in the liver is very huge in the Indian country compared to the Western countries. In the Eastern countries, now in other Eastern countries also the difference does exist, and these are of significance. Fungal abscess is usually, or rather as a rule, is a complication of a previous systemic pathology. Like either patient may have a this tumor in the liver, or it could be like a previous interventions in the liver, or patients who have immunocompromised conditions only develop the fungal abscess. So we will not deal with these conditions separately. We will limit ourselves only to amoebic and pyogenic abscess. Fungal abscess I will not just go in, because fungal abscess is always a result of some other pre-existing pathology, and outcome is extremely poor, and the important is the treatment of the pre-existing pathology. So we will focus on amoebic abscess first and pyogenic abscess next. Amoebiasis, infection of protozoal infections, particularly Entamoeba histolytica, is common almost throughout the world, but certain of the countries it is lesser. Particularly India, the intestinal and pulmonary amoebiasis, both intestinal, extra-intestinal amoebiasis is more common in Indian subcontinent. Rest of the areas is not our concern. So it's one of the areas where the incidence of amoebiasis is very huge, significant in India, and very common disease. The amoeba has a pattern of life cycle. Instead, it's actually ingested through the food, and it will have two stages: the trophoblastic stage and the cystic stage. Encystic stage, usually it's in the encystic stage. Cystic stage, it is swallowed and it develops into a trophocyte, and in the colon it produces intestinal amoebiasis. The intestinal amoebiasis is differentiated from the bacterial colitis or amoebic colitis, and bacterial colitis is differentiated from the clinical course. Clinical course of infective or bacterial colitis will be very severe, short duration, frequency will be more. Whereas amoebic colitis, the frequency is lesser. There would be more of mucus, more of feces, and lesser amount of the mucus, and the frequency is lesser. Clinical course is milder. That's about the intestinal amoebiasis. But intestinal amoebiasis also can result in an extra-intestinal manifestation, and that's the liver. So today we will be limiting only on the extra-intestinal, the liver pathology. Intestinal manifestations of the amoebic abscess and their management principles I will not deal with now. Maybe when we go into the disease of the colon, we will refer to that part. So, extra-intestinal manifestation of amoebiasis can occur even without a obvious clinical history of the intestinal amoebiasis. Though, as per the theory, it's always after the course of intestinal amoebiasis, but many of the times the intestinal amoebiasis may not be clinically identified, either due to the ignorance of the patient or many other reasons. It may not be identified, and that makes a problem in the clinical condition, because whenever a patient has a amoebic liver abscess, we will be definitely asking the question about the previous history of intestinal episode, symptoms of intestinal episode. In the absence of those symptoms, you cannot rule out amoebic abscess. That's all the point. Like, that's the important point. And another important is that for the amoebiasis, usually the standard would be the stool test. A presence of the amoeba in the stool, a positive stool test, may not confirm the extra-intestinal amoebiasis, because the amoebiasis is so endemic in our area, particularly in the coastal area. Amoebiasis is very endemic. If you go for the stool test, a large number of people may have the amoeba in the stools, but they may be absolutely asymptomatic. So that's a very interesting issue. If you go for the fecal test here, a large number of the people would have amoeba, and that they would be asymptomatic. There will be no symptom at all. Many of the patients who have amoebic abscess or intestinal amoebiasis, particularly amoebic abscess. Now, intestinal amoebiasis, of course, they will be positive. Patients who have extra-intestinal manifestations like liver abscess may not show the stool test also. Stool test may be negative. So, the point is, stool test which is one of the benchmark, the standard test for the amoebiasis, is not very dependable. It can be erroneous on both the sides. Hence, a serological test is now developed, and very recently a serological test for the amoeba has come into the practice, come into the vogue. At present it is quite costly and a few centers only have that facility. But maybe in future a serological test for amoeba is more dependable and it will be more practicable in the clinical diagnosis than really the stool test as such. Clinical symptoms of the amoebic liver abscess. Now, see, intestinal amoebiasis symptoms are different. I am talking only about the extraintestinal manifestation. A large number of patients may have the silent zone or a period of a silent period after the intestinal manifestation, which may extend up to about 3 to 10 weeks. Till then, the patient may not have the symptoms. Then, when the symptoms occur, the symptoms also will be quite diverging. Now, based upon the frequency of these symptoms, the maximum of the patients, about 81% of the patients, would have fever and a sign of tenderness in the right upper quadrant. Right upper quadrant pain and fever, these are the most common clinical symptoms. In addition to these, the other clinical symptoms and signs which may occur could be weight loss, nausea and vomiting, anorexia, pain in the shoulder area, weakness, chills, abdominal pain in general, vague pain, night sweats, rigors, diarrhea and pleurisy, dyspnea, cough, or the signs like jaundice occurs only in a few of the patients. Remember, liver abscess doesn't present with the jaundice in all patients, only a few of the patients, particularly when the abscess is located near the port diabetes, then only the patient may develop jaundice. Otherwise, the jaundice is absent. Hepatomegaly also seen in only a few of the patients. The radiological sign, one of the typical radiological sign is elevated this diaphragm. Diaphragm is raised, which is a important X-ray sign. Also is positive only 11.3%. And hence, the most dependable clinical this evidence of making the diagnosis is radiological, particularly either ultrasonography or the MRI. Typically, in a case of amoebic abscess, the abscess cavity is seen as segmented, and usually the abscess is single. So, amoebic abscess is usually single. One abscess is seen. Multiple abscess in amoebic abscess conditions are rare. I don't say that it's never possible. Whereas in a pyemic abscess, pyogenic abscess, the conditions are more multiple abscesses are more frequent. And when you look at the image of these amoebic abscess would show some segmentations, debris substances, or some thickening around the periphery due to the fibrosis. Ultrasonography also shows the same irregular shape and heterogeneous substances present in usually the if you aspirate the pus, it will be chocolate, the anchovy sauce color, somewhat a sauce color as such, and thick. There will be blood clots seen, and this also can be seen in the ultrasonography as a part of that heterogeneous content. Now, in a typical pyogenic abscess, the contents are relatively homogeneous due to the pus, and most of the times there will be multiple, whereas amoebic abscess, that debris is a characteristic feature. So, radiological imaging like ultrasonography or MRI, that can help in making the diagnosis of amoebic and pyogenic abscess, differentiating them easily, because the clinical symptoms are similar. In a typical pyogenic abscess, the abscesses are multiple and the abscess cavity is having a clear-cut border, and the contents are homogeneous. That's the typical presentation of a pyogenic abscess. Pyogenic abscess also can present in various stages, early stage of edema, where you can see over this image, as well as an abscess developed abscess. Like some status of pyogenic abscess where there is only a edema and then there is a real fluid formation. The differentiation between that amoebic liver abscess and the pyogenic liver abscess are mainly when you go into the blood picture, the peripheral blood picture, the pyogenic abscess would show polymorphonuclear leukocytes counts elevated, whereas amoebic liver abscess is generally not elevated. Occasionally, eosinophilic count may be raised. Then the incidence in case of amoebic liver abscess, the incidence is from our status, like in India, incidence is more in younger males, whereas pyogenic abscess is usually seen in old age. And usually patients who have the other history like diabetes or gallstones, etc. Then, yeah, of course, blood cells, as I said, that the polymorphonuclear leukocytosis is common in case of the pyogenic abscess. The bilirubin level is not raised in all patients. Only a few of the patients of amoebic liver abscess, bilirubin level is raised, whereas bilirubin level is raised in majority of patients in pyogenic conditions. And albumin level is reduced, whereas in case of amoebic liver abscess, the albumin level is not affected significantly. Otherwise, the clinical presentations can be similar. Now, dealing with the amoebic abscess, the amoebic drugs, anti-amoebic drugs which are used are many, and they are classified as the tissue amoebicides and luminal amoebicides. Luminal amoebicides are mainly preferred in case of intestinal amoebiasis, whereas for extraintestinal amoebiasis, usually tissue amoebicides are used. Among the tissue amoebicides, the major group are metronidazole and its derivatives. Metronidazole, tinidazole, and ornidazole are the derivatives. Then alkaloids are emetine and dihydroemetine. Chloroquine is other for extraintestinal amoebiasis only. Chloroquine is exclusively used for extraintestinal amoebiasis. Then diloxanide furoate and niacinamide, they are primarily used for luminal amoebiasis, not for the extraintestinal. Hepatic pathology, tetracycline, these are not used for the liver pathology. Liver pathology, it's only the tissue amoebicides are preferred. And the standard protocol of treatment for this extraintestinal amoebiasis is initial treatment of amoebic liver abscess is metronidazole 750 mg. This is the standard protocol given by the All India Institute of Medical Sciences, AIMS, and the standard is for adult it is 750 mg for 7 to 10 days, whereas in pediatric 35 to 50 mg per kilogram per day. And the tinidazole is 2 grams once per day orally, and for the clearance later, after 10 days of treatment, for prevention of the cyst formation and excluding the cyst, iodoquinol or thermomycin are given for 20 days. The usual course is a minimum of 3 weeks. So 7 to 10 days metronidazole, then iodoquinol. This is the standard protocol of the treatment. That's medical management. Then criteria for the intervention. So when the size is less than 6 centimeter and no feature of rupture and there is no significant compression effect, like and once you have started the treatment, if the symptoms reduce by 48 to 72 hours, continue with the drug therapy only. If the patient doesn't show this, or if the size is more than 6 centimeters, or there are no obvious evidence of rupture, but there is a possibility of impending rupture, or if there is multiple abscesses, and if there is a failure of improvement, then aspiration is suggested, and preferably USD guided aspiration is done in those patients where there is no rupture and size is around 6 centimeter, equal to 6 centimeter or more than that, or is USD guided aspiration. A percutaneous drainage where you put a drainage tube would be when there is a USD guided aspiration has failed, or if there is a secondary infection. In that condition, you will have to insert a tube and keep that tube till the drainage is reduced. A laparotomy and open drainage is indicated if there is a rupture or if there is a features of peritonitis or complicated with the pleural effusion. That's in such conditions is suggested. That's about hepatic amoebic abscess. Then the pyogenic abscess will, of course, pyogenic abscess, the source of infection is mainly from the viscera, and the passage could be either through the bloodstream or through the bile ducts or through the portal vein. So any source of infection which is present in the abdomen can result in a hepatic abscess. The pyogenic liver abscess, of course, this is the same which you have discussed. The clinical presentation would be mainly of a high degree of fever, and then there is the pain and tenderness in the right side. Patient may have jaundice clinical signs as and radiological signs we have already referred to, like where there is usually multiple abscesses, and the abscesses would have clear-cut accumulation of the pus as such, and the borders there is not much of a heterogeneous substance. Common organisms which produce are either E. coli or Klebsiella or Staphylococcus or Streptococcus. These are the common organs. The standard protocol of antibiotics, choice of antibiotics as suggested by AAMS again for India. Now this prescription is for India because you have always a chance of overriding the semiacids. The standard guideline for treating the pyogenic abscess would be, if it is an inpatient, ceftriaxone 1 gram IVBD plus metronidazole or amoxicillin clivinate at a high dose IV. As an outpatient, it's amoxicillin orally or cefixime orally with metronidazole is given. That's the standard treatment. That again, in an abscess, if it is rupture, the surgery is treatment. And the criteria for other intervention would be, if it is less than 3 centimeter, then antibiotic therapy. Now, the criteria of the size for amoebic and pyogenic abscess would be different. For the amoebic abscess, you can wait up to 6 centimeters. Whereas for the pyogenic abscess, if the size is more than 3 centimeters, then it needs to be intervention has to be done. And the intervention would be percutaneous drainage if it is a single abscess, and if there is a multiple abscesses, then surgical drainage, open drainage is necessary. If the percutaneous drainage is not successful, then surgical drainage is preferred. The majority of the patients can respond to antibiotic therapy. Only when the antibiotic therapy becomes unsuccessful, then the patient may require a percutaneous drainage if the size is less than 3 centimeters. That's about the pyogenic abscess as such. With this, we will end up today. The next is about the cysts in the liver in the next session. If there are any questions, we will try to answer the questions and then conclude. Of course, there are many questions like, which company Smrits are? Usually I prefer Dutapeshwara, but again, right. Others, of course, adverse reactions, that's another issue. I generally prefer Dutapeshwara. Then there is another is Arogyavardhini itself contains copper. Okay, that's fine, absolutely. And it's very interesting issue. I have seen the patients having relief, and the copper and Tamrabhasma, these are two different issues. Tamrabhasma is a bioassimilated form of the copper, and it cannot be compared to the copper as such. So that chemical name and the Ayurvedic protocol of preparing the drugs like Bhasma preparation, these need not be matched together. That's the ultimate. Then what's the understanding of conditions like Wilson's disease or Indian childhood cirrhosis from Ayurveda? Of course, it's very difficult to say. Maybe they are, because the description of the liver disorders in Ayurvedic text is very less. So maybe they are all varieties of the Udara, Yakruta Udara, maybe the Kapha Udara, Kapha Dosha Dushti. Then is the plan of management of these conditions based on the pathology? No. The management is mainly based upon the issues of the Udara management. There is no such specific issue or a specific description. As far as the Bringaraja is prescribed, Bringaraja is prescribed in with an idea of using the drug in Tamra Marana, as I told you. So whether it is an Ayurvedic view or whether it is a corrupt view, contemporary, you may judge on yourselves. But I have selected Bringaraja in patients of hemolytic jaundice, where there is a deposition of iron, as well as in the case of Wilson's disease where there is a deposition of copper, because Bringaraja is used in conditions of or in the Marana of these lohas. Then when to use Asava in liver disease? I think that question has no significance. Asavas, any Asava can be used if it is given properly, if it is prepared properly. Then like Punarna Asava or Kumari Asava. Okay, Punarna Asava is when the patient has a pedal edema, chronic hepatic failure. When the patient presents with pedal edema, Punarna is preferred. When the patient presents with the Agnimanjya Lakshanas, I would be preferring the Kumari Asava. Then Nitya Virechana is indicated in, see there is, I don't accept anything as a Nitya Virechana. So there is nothing like a Nitya Virechana. Virechana is a course of the treatment where you have to follow the protocol of Snehana and the Shakha, the Kosta, Dosha, Chalana, and then the Asana Marga, Nirhat. So that's the total course of the Shodhana. There is nothing like a Nitya Virechana. Then the concept of the Nitya Virechana itself is something different where you give some purgatives regularly and it's not a Shodhana karma. So that controversy, of course, it's a issue of controversy. We can have that discussion about that controversy on some other sessions, like it's a point of debate rather. So you'll stop at that part. Right. There are no more questions. Right. Okay. Fine. Thank you.